Bronchitis refers to inflammation of the trachea and the bronchi. So we'll be talking about two major kinds of bronchitis, acute and chronic. Acute bronchitis refers to short-term inflammation of the trachea and bronchi. About 80% of cases of acute bronchitis are viral in origin, but they can also be caused by bacterial infection or by physical or chemical irritation, such as exposure to heat, smoke, irritating chemicals, and allergens. Acute bronchitis is essentially an inflammatory response to something that's irritating your airway. So your capillaries dilate, they release more fluid, which leads to edema. There's infiltration of inflammatory cells, there's an increase in mucus production, ciliary function is lost, and some portions of ciliated epithelium may be lost. Ultimately, this leads to some obstruction of the airway. Bronchitis has a more specific definition. It's defined as hypersecretion of bronchial mucus with chronic, recurrent, productive cough that lasts for more than 3 months and recurs yearly for at least 2 successive years. About 90% of cases of chronic bronchitis are caused by cigarette smoking. They can also be caused by repeated airway infections, genetic predisposition, and again, long-term exposure to physical or chemical irritants. The effects of chronic bronchitis are that of chronic inflammation. So long-term inflammation leads to scarring, increased fibrosis of the mucous membranes, hyperplasia and hypertrophy of the bronchial mucus glands and goblet cells because they've been working overtime for a long time, and increased bronchial wall thickness. Ultimately, these changes again lead to airway obstruction, which is why chronic bronchitis falls under the umbrella of chronic obstructive pulmonary disorder, or COPD.
Okay, now we're going to do the clinical manifestations of bronchitis, both objective and subjective. So for acute bronchitis, there are many more clinical manifestations. Some of the objective ones include the cough, which is the most common symptom and lasts up to 3 weeks. It is often a productive cough with clear mucoid or purulent sputum. Patient will often have a low-grade fever, experience hoarseness, rhinorrhea, which is a runny nose, pharyngeal erythema, which is redness, swollen lymph nodes. Their breath sounds may be normal or with some bronchi and crackles, and often they also experience wheezes, usually on expiration with exertion. Some of the subjective clinical manifestations include the patient feeling malaised or extreme fatigue. They'll complain of dyspnea and chest pain. Quite often they will also have a sore throat, headache, and myalgias or muscle pain throughout. A lot of these manifestations are indicative of an infection, which is usually what causes the acute bronchitis. For the chronic bronchitis, more specifically, the manifestations are a productive cough that lasts for more than 3 months and occurs for at least 2 years continuously. We also have wheezing that is evident with chronic bronchitis, and a lot of patients will complain of chest discomfort. Chronic bronchitis doesn't have as many clinical manifestations as the acute bronchitis due to the fact that their bronchitis isn't due to an infection, so they won't have the extra clinical manifestations of fever or anything like that that indicates that your body is trying to fight off an infection.
I will be going over the expected lab results for acute and chronic bronchitis. First, bronchitis is diagnosed by confirming the presence of airflow obstruction on a patient. Pulmonary function tests may show expiratory airflow obstruction, including a low forced expiratory volume. This is done by using spirometry, A forced expiratory volume less than 70% indicates moderate severity, 30 to 50% indicates severe, and less than 30% indicates very severe. Basically, the lower the forced expiratory volume, the sicker the patient. Arterial blood gas determines how well lungs are getting the oxygen into the blood and carbon dioxide out of the blood. Laboratory values for arterial blood gas are usually assessed in the severe stages, such as forced expiratory volume less than 50%. These are monitored in patients hospitalized with acute exacerbations. Abnormal arterial blood gases may show compensated respiratory acidosis, which is a decrease in partial pressure oxygen and an increase of partial pressure carbon dioxide. Careful assessment of patients with arterial blood gas for any movement towards respiratory acidosis and further hypoxemia may indicate respiratory failure. Other results, such as chest x-rays, will show hyperinflation of the lungs, a flattened diaphragm, and may display a cardiac enlargement. Chest x-rays can help confirm diagnosis of chronic bronchitis and rule out other lung conditions at the same time. In addition to the chest x-ray, a high-resolution computed tomography, a special type of CT scan, can provide a high-resolution image of the lungs. Sputum examinations, such as analysis of cells in the sputum, can help determine the cause of some lung problems, whether the patient's been exposed to dust, fumes, vapors, or air pollution. Oxygen saturation may present less than 88%, qualifying the patient to receive supplemental oxygen, which is frequently used in the treatment of COPD, such as chronic bronchitis and other problems associated with hypoxemia.
Okay, so I'm going to be talking about collaborative care and treatment for acute and chronic bronchitis. There isn't too much that your doctor can do with acute bronchitis. He will refer you to a radiologist to get a chest x-ray to see if there is any signs of pneumonia. If there are no signs of pneumonia, the doctor will send you home, which is kind of a bummer. There are no antibiotics that the doctor can prescribe you either, because mostly it is a viral infection. He will, however, send you home with an order to get lots of rest, to drink lots of fluids. He might prescribe you an anti-inflammatory agent such as prednisone, which suppresses the inflammation and boosts the normal immune response. He will tell you to get some cough suppressants such as Robitussin and Mucinex. He might prescribe you a bronchodilator such as albuterol or Perforomist, which helps allow that airway to expand. Now with chronic bronchitis, you go and see your physician because you've had that nagging cough for more than 3 months. He suspects chronic bronchitis, but he wants you to go to radiology to help rule out any pneumonia. Again, if there are no signs of pneumonia, you will get a referral to see a pulmonologist. The pulmonologist specializes in lung disease, and it is very critical to treatment. He will order the medications as well help manage any difficult airway problems. Then you might also see a respiratory therapy team. They will help with breathing exercises as well as strengthen your diaphragm to help make breathing easier. For treatment with bronchitis, you might also get a bronchodilator, which helps allow that inner airway to expand. You might get a steroid, which helps reduce the inflammatory reaction and thus decrease the bronchial swelling. The doctor might also prescribe you a PDE4 inhibitor, which is a class of anti-inflammatory agents. You might get sent to pulmonary rehab, which helps combine education and physical exercise. The doctor might prescribe you supplemental oxygen, which might help you sleep better. And again, you might relieve your cough with that cough suppressant such as Robitussin or Mucinex.
Acute and chronic bronchitis nursing diagnoses. Some of these nursing diagnoses pertain to both acute and chronic bronchitis, and some pertain only to acute or to chronic bronchitis. For acute bronchitis, we have ineffective airway clearance related to increased production of secretions, acute pain related to the inflammation of the pleura, impaired gas exchange related to airway obstruction by secretions, spasm of the bronchus, and altered oxygen balance, ineffective breathing pattern related to bronchoconstriction and mucus, imbalanced nutrition, less than body requirements related to dyspnea, anorexia, nausea, and vomiting, anxiety related to change in health status and potential chronic condition, sleep pattern disturbance related to difficulty breathing, and impaired respiratory function related to ineffective breathing pattern. For chronic bronchitis, we have ineffective airway clearance related to increased production of secretions, impaired gas exchange related to airway obstruction by secretions, spasm of the bronchus, and altered oxygen balance, ineffective breathing pattern related to bronchoconstriction and mucus, imbalanced nutrition, less than body requirements related to dyspnea and anorexia. If you remember on the previous slide, there was also nausea and vomiting added to that one for acute, but not so much in chronic. Activity intolerance related to insufficiency of ventilation and oxygenation. Knowledge deficit related to the lack of information about the disease, process, and treatment at home. Ineffective health maintenance related to deficient knowledge regarding the care of the condition. Readiness for enhanced self-health management, wishes to stop smoking. Sleep pattern disturbance related to difficulty breathing, and impaired respiratory function related to ineffective breathing pattern.
Hello, the next portion of the PowerPoint is going to be the potential complications of bronchitis, as well as their rationale. The first one is going to be the ineffective airway clearance. This is going to be related to retained secretions. Some of the signs and symptoms include decreased oxygen saturation, below 90% on room air, bronchi crackles, and wheezes on expiration. Our prevention in this can help by clearing out the mucus from the lower lobes of the lungs, which can prevent that bodily fluid stasis, because that's where the bacteria are going to want to hang out. The rationale behind this is that the controlled coughing that we're going to have them do uses the diaphragmatic muscles, making the cough more forceful and effective. The next one we're going to have here is going to be a risk for infection, because they couldn't possibly get out some of that fluid in the lungs. The signs and symptoms of this are going to include fever, irritability, chills, increased coughing, rhinorrhea, again bronchi and crackles, and wheezes on expiration. The prevention step is going to be to stay adequately hydrated. It's important to help with the insensible fluid loss. The rationale behind this is that fluid intake helps to thin out those secretions, making them easier to cough up. It also helps replace fluid loss during the fever. Lastly, we're going to have the risk for sleep deprivation. This is going to be related to prolonged discomfort from all that coughing. The signs and symptoms include daytime drowsiness, fatigue, inability to concentrate, and irritability. The prevention step is going to be possibly to engage a physician so that we can get something to help with the pain and coughing, such as bronchodilators, Robitussin with codeine, and Mucinex. The rationale behind this is that the symptomatology of physical disease states can interrupt and even shorten sleep. That concludes our PowerPoint. Thanks for watching, everyone.